function, and then the kidney and electrolyte balance. I do have to say that students tell me that they hate kidney. I think there's maybe a few reasons that they hate kidney I can think of, but anyway, just a heads up in case you need to kind of start reading kidney as soon as possible. I always hear that. It's like, I can't stand kidney, it's too hard. Anyway, but the lungs usually people take it very easy. Intuitively almost. Okay, let's get to chapter 17 because a lot of you ask about question of the day, and since I didn't say specifically that I'm going to be doing it, so that means that I'm specifically telling you that on Thursday you're going to have 2 questions of the day for chapter 17 and chapter 18. Okay, you'll be warned now. Because I did respond to some emails and I thought, it's okay. I'll just tell them now. All right, so next Thursday, 2 questions of the day, okay? Okay, let's get into the lungs. Respiratory system. So, when it says gas exchange, what are you guys thinking? What does that mean to you? Gas exchange. Sarah?
Breathing.
Breathing specifically. And then, can you elaborate a little bit? What do you mean breathing? Breathing what?
You breathe in O2 and
You breathe in O2. You breathe in CO2 too, but in a smaller percentages, obviously. But it's the most reason is of course to take in O2, right? And then what about CO2?
Breathe out.
To breathe it out, right? CO2, guys, why should we breathe it out? We do have to breathe it out. Kate?
Too much of it in our body would cause respiratory
Acidosis, yes, acidosis, CO2, water, carbonic acid. So let's remind ourselves quickly that cellular respiration reaction because it's actually gonna come handy. Let's start with the glucose. Who remembers the formula? C6
H12
6. Take a breath. This is why we're breathing. So series of chemical reactions, glycolysis, citric acid cycle, oxidative phosphorylation. And then this is a summary reaction, right? So we're not getting details in other biology 107 here. And then what's the result? CO2 out, water, and of course, very importantly, ATP plus heat. And this is a form of energy, right? So, the only reason we care about oxygenation is that we can do this, really. There's not that much use of anything else. We need an ATP to move around, to do transport, to contract our muscles. A bunch of chemical reaction depends on ATP. So it's a mechanical work, chemical work, transport work, all relies on ATP, all your pumps and stuff. So you need to make it, otherwise, and of course, if you guys remember the muscle contraction, right? ATP has to be available for the muscle to contract. So then this whole point of breathing is to bring the oxygen, and also, because this is a byproduct, we have to remove it. So we don't get into respiratory acidosis or metabolic acidosis for that matter, if you can remove it. Okay. So the pH regulation specifically speaks to that, right? How are we going to regulate pH? We know, right? So the kidney would be a second line of kind of help with the pH changes, but the respiratory system first. The easiest, fastest way to change the pH is through manipulating your breathing, either hyperventilate or hyperventilate. It does have a function for assisted immune system to protect, like a first line of defense. Remember we mentioned pathogen substances. They get stuck in our mucus, in our upper respiratory tract, and then we could clear them out. Mucociliary escalator, that name refers to ability of cilia, which is a hair-like extension on the epithelial cells of the upper respiratory pathway to beat outward. So cilia, these hair-like extensions, some of them that we can clip in our noses, but they are present throughout upper respiratory tract. And so their job is to beat outward. And so, not only that, but also production of the mucus, so the pathogens and dust and particles to get trapped and then pushed out. This is to protect the lungs, right? And once you have a mucus, of course, you can swallow it, you can spit it out. I have a friend who runs, and I swear to God, the movement that she makes with her respiratory muscles to clear her mucus, it's pretty horrible to see. But she swears that is how she stays healthy, and that's true. I mean, she's 70 years old, running like crazy. I don't think she's ever been sick. She just, everything comes out. I'm like, oh my God. But it does work. And of course, speaking, right? Without the air passing through your larynx, you wouldn't be able to make a noise. If you're going to not breathe, and I was gonna say try to talk, you can't, right? You really have to get the air go through. So lots of function. Okay, so then air needs to come in. And guess what? Just like with cardiovascular system, air travels down the pressure gradient. So that means if you want for the air, atmospheric air, to get into your lungs, the lungs need to have lower or higher pressure? Lower, because it has to be lower than the atmospheric, right? Otherwise, atmospheric has no point of going in. Are you with me?
Mm-hmm.
So we'll talk about that a little bit more. Then we're going to talk about our muscles that will create the pressure differences by expanding and contracting the thoracic cavity. There'll be a resistance to the flow just like in cardiovascular system, because if you have the bronchial constriction or dilation, it does exactly the same thing as a vasoconstriction, vasodilation. So diameter of the respiratory tract tubule will play exactly the same role and be resistant to the airflow. So in that respect, it's kind of similar, and you can draw that same physics that we talked about during the cardiovascular system would apply here as well, except we're dealing with the movement of air as opposed to blood. Okay. So O2 will enter the alveoli through the upper respiratory pathway, and it needs to go from alveoli of the lungs to the blood. Oxygen also travels down its concentration gradient. So what does that mean then? What would make oxygen go from alveoli of your lung to the blood? Brian?
High concentration to low concentration?
So where's the higher concentration? Alveoli or blood? Has to be an alveoli, right? Because down the concentration gradient.
Yeah.
So it has to be lower here and higher here to enter. This will happen, this is very, a simplistic way to do this, but we'll get into details. It's a very thin layer and then and the capillary. So there's like very thin membrane to overcome for the O2, which is not a problem at all. Let me just grab the Brian. So down the concentration gradient. So, goes through the pulmonary circulation, gets to the systemic circulation, and here's our cell doing cellular respiration, as everybody should, every one of our cells should. And they're using the oxygen, and they're producing CO2. So what would invite the oxygens come from here to here? Because that's another situation needs to happen, right? the fact that the oxygen is in the blood is great, but it's the cell that needs to take it, right? So the oxygen could diffuse through the membrane, no problem. Do you guys remember CO2, O2? Simple molecules, non-polar, through the membrane, phospholipid barrier, no problem. So, but the concentration gradient is super important, otherwise there is no advantage to go. So what would make the oxygen go from blood to the cell?
It's lower in the cell.
The concentration of oxygen should be lower in the cell. And it would be if this oxygen is being used up and CO2 is being produced, right? You guys understand that? So then CO2. CO2 is being produced. Here's the CO2, it needs to get into venous circulation, obviously, so that it can actually get out. So what would make CO2 go from here, from the cell, into circulation? Same law, James?
There's a lower concentration of CO2 in the blood.
Yes, so cells are making CO2, right, as a product of cell respiration. So the concentration of CO2 is rising in working cell. So the blood should have low concentration of CO2, which it would be as it arrives. You see that little purple in between? So it's coming in oxygenated, right? But so the concentration is not high yet. But here's the exchange, and now the concentration, of course, higher than it was before it entered the cell, or like flown by the cell, because it's a capillary gas. It's very, very quick exchange. So concentration of CO2 also travels down the concentration gradient. Just keep reminding yourself, air travels down the pressure gradient, the gases travel down the concentration gradient. Okay, say it to yourself. The air enters down the pressure gradient and the gases travel down the concentration gradient. Do you guys understand that?
Can you repeat that?
Yes, so air travels down its pressure gradient from high pressure to low pressure area. That means atmospheric air should have a higher pressure than the alveolar air, right? Otherwise it wouldn't enter. It's not like they're trying to balance, molecules always move where there is less of them.
But once the cell has more, then it goes back to the slug, right?
Well, this is a different molecule though, CO2 now.
Okay. Oh, yes, I
CO2
see.
has a high concentration because of this. It's being produced,
Yes.
so that the buildup is CO2. So less O2 here and more CO2 here. So CO2 also goes down its concentration gradient, okay? From high in the cell to low in the blood. So this is very important principle, because that's gonna really help you understand a lot of different things that's coming up. Quick anatomy, of course, in the upper respiratory system, we have nasal cavity, we have the pharynx, vocal cord here in the larynx. So, and then after the larynx, so the trachea, both of the left and the right bronchos and the left and the right lung, they are part of the lower respiratory system. So cuts up about here at the trachea, upper and the lower. So now the lungs, they don't just like float around, right? They sit in a very specific area that we call pleural cavity. So the pleural cavity has a few components to it. So first, we obviously have the ribs that kind of define the area where the lungs are going to be resting. Diaphragm is not showing here, but you know, here. It'll come up, I'm sure. Or maybe, oh, here you go. Here's the diaphragm here. So that's your kind of the bottom layer, level of, not the level, border, I guess, of the thoracic cavity. And then very importantly, bless you, very importantly, is something they're called pleural cavity, which is this in gray over here. And look how it folds around. So your book has this very good picture, which I may, I don't know if I added there. So think of the pleural cavity as like I think they had a balloon, and you just feel like you push your fist in there. So it actually has two layers. This has happened during embryonic development, but it is two layers, but they kind of connected. So imagine it's a one balloon, and you just kind of pushing your fist in there, so it kind of bends around it. That's how the pleural cavity is around the lung. And it's kind of very important because over here, it has a negative atmospheric pressure, and it does a lot of different things. So it's actually protects from like friction, from sticking to the wall of the ribs, and we differentiate two different pleural membrane. So the visceral will be the one that's on the surface of the lung. It actually adheres to the lung, and the parietal would be the one that closest to the ribs. So parietal and visceral pleura. So that's that picture. So that's kind of just a visual to say that this is a continuous structure, and here's your air of the lungs located within the pleural cavity. It's a very, very small layer. If you look at this in the relay, it will be like a millimeter. It's a very tiny area, and friction, protection from abrasions. It has a little bit of the serous fluid, which has mostly water, but they also have some surfactants. We'll talk about that a little bit later. Okay, and then when we go from the trachea, just a kind of overview of anatomy a little bit, is the trachea divided, as guys you probably know, to the left and right primary bronchus. Those are two, just the two, and then they further divide into secondary bronchi, and then bronchioles, and eventually bronchiole will terminate in what we call alveoli. On this picture, so here's your, okay, they cut it out, there's something after here. Okay, this is our alveoli. So alveoli are right here. So this would be our most terminal structure of the lung. And of course, there's millions of them, of the alveoli. So alveoli is the area where the air exchange is going to take place. So this is the alveoli. This is where the air is going to exchange. So here's the thing. This is a very important slide because it feeds in a lot of understanding. So it seems very simple, but here's first is our, what we call a type 1. What is this pointed here? Oh, I guess it's just pointing on the cross sections. But these guys are actually a type 1 alveolar cells. All this purple one are the type 1 alveolar cells. They just for some reason just pointed it on the cross section of it. So, and these guys are super important. They called the type 2 alveolar cells. And what their job is to make something they call surfactant. We'll talk about surfactant and all. It almost acts as it's very similar to the structure like the dishwashing fluid. And what it does, surfactant prevents alveoli from collapsing on itself. Think about it. If you have like a little plastic bag and you put a little bit of water in there, right? Do you feel like it's going to stick to the both leaves gonna stick to each other, right? It's gonna take a lot of energy to blow them apart, but with the surfactant, it's like if you would add a little bit of a dish soap in there, it will separate much easily. So what the surfactant does in this situation, because we're at the very terminal part of the lung, it's a very one cell wall alveoli structure, they would collapse if they would not feel surfactant. And then the breathing in would be a laborious activity. So surfactant prevents alveoli from collapsing. And the surfactant is produced by the type 2 alveolar cells. very, very important. We'll mention that a few times. What else you see? Alveolar macrophages. Their, of course, job is to do phagocytosis. If anything that actually pass through your mucociliary escalator, then they will try to take care of that. Here's our capillaries, which is of course ready for the gas exchange. And so here's, you can see, capillary, endothelial cell that belongs to the capillary. Here's your type 1, main alveolar cells. And so, and the basal membrane that's the only distance that the air really has to travel from here to here to get into circulation. So a very nice system, unless of course there's a disease. And we'll talk about that. The other important part here is the elastic fibers that are present between alveoli. And that is because, imagine, if you take in the breath in and the lungs extend, it kind of needs to go back. A little bit like an artery, but not to the extent, like not snap back, just go back. Because if there are diseases that actually, like emphysema, when the people lose the elastic fiber, and so you take a breath in, easy, like, but then they don't snap, I shouldn't use the word snap, they don't go back to come back to the original, so the exhale is very difficult. So there is a lot of stagnated air. So both important, to be able to expand and to be able to come back so that you can release that air. So what else is here? Yeah, those are the key things. Please make sure that you've had a chance to study the slide and know these key cells here. Not a very complicated system here, but very efficient. Okay. Respiratory system, and especially to begin with the upper respiratory system, has a very important function to warm the air to the body temperature. So just by traveling through the nose, pharynx and larynx and trachea, the air gets to be not only moisturized, and in the water vapor, and also warmed up. Very important. If the air is dry, if the air is too cold, it's going to kind of acclimate to the room temperature, because in the alveoli, where the gas exchange is, you've seen, the structure is quite simple. They don't really have a capability, there's no cilia, they really don't have a capability to be dealing with the air. At that point, it's all about the air exchange. So most of this warming and added water vapors and filtering foreign materials, this all happens in upper respiratory tract. And you guys probably, I don't know about San Diego part, but if anybody been in a colder climate, people very often will have their scarves over their faces to aid the warming of the air, right? Because then if it's so cold, just when the air travels, there may not be enough time to warm it up efficiently. You've seen people like putting their over noses. What they're trying to do is just to keep the temperature low in that. And of course, once it finally gets to alveoli, you'll go to capillaries for the pulmonary circulation. And we know, right, ventricle, pulmonary artery, really trunk here, pulmonary arteries, lungs, pulmonary veins, and the left atrium, and the air exchange took place. This was an interesting anthropological research I saw, and I thought maybe after what we just talked about, you can guess why do people have different shaped noses, and specifically, I'm talking about narrow and long, and wider and shorter. Any idea? Steven?
This is just a guess,
Of
but
course.
maybe skinnier and longer in colder climates, because it allows, more
time to travel?
to travel and thus warm up.
Okay, that's one guess. Another guess.
Like the size of the body or the capacity of the lung, maybe? I mean,
It has to do with the
like
capacity of the
yeah.
lung. lung capacity. They didn't find correlation between size of the body, but they did find correlation between where the ancestors of the people with the shorter, wider noses and the longer, narrow noses came from. So, and it is actually, turns out that the colder climates, it doesn't have to be you live in cold climate right now, it means your ancestry in the colder climates have actually narrow and the longer noses. And the theory is that it does condition air better than the shorter and the wider noses, and those usually in the warmer climates. Isn't that kind of fun? A little bit of a connection between the anatomy and the survival ability, because if you think about that, during the times when, evolutionary history, when there is maybe a less opportunity to recover from the, respiratory infections and not modern medicine or what have you, having a longer and narrow nose does allow for the air to warm up better. So that seems to be what these anthropologists decided to, that seems reasonable, not decided to, hypothesized. It's a theory, as everything is, right? Everything is a theory. All right, so now let's talk about this mucociliary escalator. Isn't that a funny name? So, here's our epithelial cells in the upper respiratory upper respiratory pathway. And look at these cells. Cells are ciliated. And in fact, when we first talk about tissues, we said, oh, where are we gonna find cells with cilia, hair-like extensions? We said upper respiratory, we said fallopian tubes, right? So, but for this one, these are the cilia, hair-like extensions. And check this out. So we have this watery saline produced by the cells. We'll talk about them in a minute. These epithelial cells. And then we have a specialized goblet cells that actually secrete mucus. So we have a mucus and a saline. These two guys together able to not only trap the dust and pathogen, and then cilia beats outward, not downward, outward, right? So you can actually capture this pathogen and different particles and actually push it up. Can you see how maybe if let's say the saline solution is not being produced very well for whatever reasons, or maybe the person is dehydrated, do you see how the mucus could become sticky, right? And then what could then happen? What it could look like to a person? James.
It would be less fluid motion, probably be very sticky mucus, and if it's really bad, it could over time lead to lung infection.
It could lead to lung infection, and in fact, people with cystic fibrosis, that's one of the complications, because their mucus is very sticky because of the effective transporters for the making saline, so it's very sticky. So the pathogen stays on, they're not actively removed. Because even if cilia, I mean, in order for the cilia to beat, guys, I hope you understand, if it's too sticky, it will just not move, right? So it has to have a saline, so it's actually could move, flow. So mucociliary escalator is very important, but you also have to keep it hydrated. Okay, so here's the cystic fibrosis. Let's talk about that, because it does give us a little bit of a kind of idea. So there is a special channel called sodium potassium chloride cotransporter, and of course the reason that's the potassium, because it's kalium, also the alternative name, so that's just the name that sticks with it. So sodium potassium chloride cotransporter. Where's that guy? Here you go. So sodium potassium 2-chloride, NKCC. So this is the ECF. This is our ciliated epithelial cells. So we just kind of rotated them, right? So here's our ECF. So what happens is this cotransporter transporters, the very important part of it, that will bring the chloride inside, and then through the different, just the chloride specific channel, it will actually get out into the, into the lumen, lumen, like the opening, right? So chloride is important because then sodium and water, they actually travel via the concentration gradient and via electrical gradient, because they follow, especially sodium, they follow towards the chloride. And as the sodium follows between the cells towards chloride, they make saline, sodium chloride. And the water, of course, keeps it, you know, to a dilution factor. So, so this is a sodium potassium pump that we already know about to kind of normalize that, and the potassium gets removed through the specialized. But the part that's important is to get the chloride into the lumen. So the difficulties with the difficulties with the cellular cystic fibrosis, actually, it is the genetic defect. And so the genetic defect in such that this particular channel, it also has a name, CFTR channel. This is the one that's not working. So even though the chloride comes in, the chloride doesn't move intracellular, it doesn't move into the lumen. And then thick, so no saline solution, sticky mucus, mucociliary escalator is not working. And just as we say, it will restrict the airways, it could lead to infection. And the symptoms are not the symptoms. The complication of cystic fibrosis is a recurrent respiratory infection. So, isn't that amazing how one transporter can cause so much damage, right? But that's how it is, everything just so interconnected. Okay. So let's learn a little bit more about that surfactant that's produced by what kind of cells? Who remembers the name of the cells? Oprah? Type 2. Mm-hmm. Very important. I'm sure I'm gonna ask that. So, where are we? Okay, red blood cells. This is our plasma, so it's like a fragment of the capillary. Here's our endothelium of the capillary. This is the nucleus of the endothelial cell. So this is all belongs to the capillary, right? The endothelial cell, very thin layer of the basal membrane. And then here's our alveoli. So this is a type 1 cell in purple. And here in blue, our thin layer of surfactant. So that is the surfactant that's produced by type 2 cells, and it stays in the alveoli to make sure alveoli not collapsing on themselves, right? So, and the job of the surfactant is to break hydrogen bonds. We'll look at the other picture that will hopefully make more sense. Make sure the alveoli do not collapse. You guys hear like that whole crying baby situation, right? That is very often to open up the alveoli. And when baby's not crying, or if the baby is premature, the surfactant production is not at the point where it could actually expand, because we have to have surfactant production or the lungs will not expand. So that's why sometimes they have to go in ICU and to help breathing. If the surfactant was not produced, or if they like, I think younger than 28 weeks, I believe 28, I may be mistaken, maybe I write it down somewhere, but somewhere around that, 28 or 28 or 26?
I think it's
20 even? Because
I mean,
surfactant production
7
kicks in a little bit later. Yeah, I may have the
But
thing.
then I read it 20 somewhere. I'm 26.
Okay, so let's think about surfactant here a little bit. So, soap-like chemical. So it is actually have this phospholipid type of structure. And what it does, remember the water molecules, they have hydrogen bonds between them. Do you guys recall that? Because remember the hydrogen are slightly positive, the oxygen is slightly negative, right? So this is within one molecule, this is one molecule, H2O, but between the other molecule, right, there's always going to be another molecule like that. And so that is the hydrogen bond between slightly positive hydrogen and slightly negative oxygen of one molecule and the other, same here. So this is the hydrogen bond. And so these hydrogen bonds, what they do is they like the water to stick to water, right? So, and also, when you think of the adhesion, when I was just giving you example, little plastic bag, a little bit of water in there, try to separate that, right? Hydrogen bonds are keeping that, you have to break the hydrogen bond between the water molecule if you want to separate them. But so what the surfactant does, it actually gets kind of in between the water molecules and improves the, decrease the tension, I guess the one way, good way to say it. So then it will help lungs to stretch during the breathing. And if you don't have enough surfactant, it's difficult to expand the alveoli. And again, same really, surfactants are part of the detergent, the dishwasher detergents, and that's why they could, will help if you add the detergent into the plastic bag, they will open up really easily. Who was right? Antonella was right. Yeah. So surfactant production begins around 20 weeks.
But it's 24 to 28 in reality.
Well,
Good
good chance to survival, but the point is it begins.
Yeah.
Right?
It
It
begins,
doesn't mean that
here
it's.
it says it begins 24 to 28, and it's done 32 to 34. I was just reading it, just to tell you.
Well, no, it begins at 20, the surfactant production.
Yeah, but now I was reading it here, so I'm just saying that you were right before when you said
Well,
27.
so when I was saying 28, this is where the kid has the better possibility of
Okay,
survival,
yeah.
it's a much more complication, stuff like that. But yes, so if, well, as you can see, there'll be very little surfactant around that time.
We're both right.
Thank you. Okay, so let's talk a little bit about the gas laws that will apply here, because the next few things we just need to really understand a little bit. So what does that mean? Total pressure equals sum of all partial pressures. So partial pressure of the gas is sort of the proportion of the gas in that mixture. So let me see if I can explain. So atmospheric pressure at the sea level is at 760 millimeters of mercury. That's given, right? And then at the sea level, the alveolar pressure is also 760. So now let's talk about, well, this is actually a little bit not what I was going to mention first, but okay, let's just finish this up. The intrapleural pressure, I mentioned to you, the pressure between the visceral and the parietal pleura is actually below atmospheric. So if this is set for 0, because they're kind of the same without any movement of the air, then -3 is referring to this. So if it's, so it is actually 757, but because we zero this out, so then it's gonna be -millimeter as compared to the alveolar and atmospheric pressure. So what that tells you is that the air in the pleural cavity has a negative millimeters of mercury, so it's below atmospheric pressure. The pleural cavity is airtight, and it's very important because if you have a pneumothorax or something, or like a spontaneous rupture of the alveoli, then that tightness is going to allow, it's going to be disturbed, right? The air will be traveling into pleural cavity and the lung could collapse. So when the reviews expect that the So the ribs going upwards. And when the ribs are expand, what happens to thoracic cavity? Is it getting larger or smaller?
Larger.
Larger. And if it's going larger, then what do you think is gonna happen to the pressure? If the pressure is equal when you're not doing anything, 760, 760, and now you extending thoracic cavity, so you have more volume, what's gonna happen to intrapleural pressure?
It's gonna go lower.
Yes.
It's gonna become lower.
It's going to become lower, because the way you have to think about that, I kind of feel like I had a better. Okay, I do have it, but just a little bit later. For some reason, I just kind of stuck to the. Okay, let me just quickly. I need to move it around a little bit. Here's your pleural fluid, right? So the when the ribs expand, they move the lungs. You know, they increase the thoracic cavity. And then what makes the lungs to go back? This is something they call elastic recoil. So elastic recoil is the action of those elastic fibers to come back. It's like having elastic clothing in, you stretch it by putting the air in, and then when you exhale, elastic recoil allows for the lungs to go back. So this is what's gonna help us. Because we said that the gas flowed down the pressure gradient, that means that we need to create a low pressure gradient in the thoracic cavity, right? The way to do it, one way to do it, is because we're not really changing the air composition between the atmosphere and the lungs. We don't do that. All we can do is expand the cavity. So if you have a larger cavity, then the same amount of the O2 here in the larger volume will have a low partial pressure, a proportion of the oxygen towards the entire pressure. So as the volume increases, the pressure decreases. And what's the pressure? Here, if this is an oxygen, it of course hits the volume, it hits the walls of the container, and it creates pressure. So if the cavity is lower, then the pressure is high. If the cavity is larger, then the pressure is lower. So the pressure in the lung must be lower for the air to enter. And again, think about this, guys. We just said 760 at the sea level atmospheric pressure. If I'm not breathing, 760 in my lungs as well. The only way to make the 760 go lower is to expand my cavity, thoracic cavity. If I expand the volume, even though it is the same amount of the oxygen there and there, but in a bigger volume, it will have a smaller partial pressure. Because the word partial means the proportion of oxygen to the other gases, right? So even though it is the same originally, but as I expand, it will be lower in my lungs because of the volume increased. And now that my partial pressure is low, it will flow in. So how do we do that? How do we expand? We take what?
Deep breath.
Inhale, right? And so which way is the diaphragm moves when we take inhale? Up or down?
Down.
Down.
Oh, down.
We need
Oh, yeah, down.
more cavity, right? We need to change our volume so it's actually down. And of course, ribs out. Ribs out, diaphragm down. Now we have a bigger cavity and the partial pressure is lower. You can guys kind of put it on your ribs and you can take an inhale. You should clearly see your ribs popping out and then inhale. So this is the only way for us to change the partial pressure of the oxygen is by creating a bigger cavity. And if the bigger cavity, the gas law states, then the pressure will decrease. How are you doing with this concept?
Good.
Okay, so let's make sure that we're clear. So we need the pressure of oxygen in the lungs to be lower. It is the same really. Partial pressure is the proportion of the oxygen towards the other gases in the atmosphere. Over there, over here, it's the same, right? Kind of the same. We'll get to details a little bit later. Kind of the same for now. Kind of the same for now. And then if we increase our thoracic cavity, now we have a bigger volume. So even though it's the same concentration of oxygen, it's in a bigger volume, so it will have lower pressure. And that will invite oxygen to get in. To exhale, it's what we have aiding the exhale is a couple things. First, very importantly, of course, our muscles. But then the second very important part is what we call elastance. Elastance is ability of the lung tissue to recoil, go back. Because if the elastance is low, and there are disorders where elastance is low, it's like a really stretched out clothing or hairbands or something like that. You stretch it, but it doesn't go back. So for lung physiology, it's called elastance. Elastance is these elastic fibers that will stretch back, go back. We call it elastic recoil. So that elastic recoils will push the air out with the help, of course, the muscles. So elastic recoil is out. So in the lab today, we're going to be dealing with your lung volumes, kind of see how you're doing. So the tidal volume, that term in respiratory medicine refers to the volume that moves during a simple inspiration, expiration, and means like you're not making any effort, you're just in and out, in and out. That's your tidal volume.
Is that like every day, like just normal breathing?
Normal breathing, tidal volume. The inspiratory reserve is when somebody asks you, could you take a deep breath? So that extra that you can do, in addition to above your tidal volume, will be inspiratory reserve, meaning your lungs are capable of it. And it's gonna be different for everybody. When you guys are gonna do that in the lab, you'll see everybody will have a very different capacity. And expiratory reserve, again, if somebody asks you, you like forcefully exhale, right? And again, that's gonna be something, on the top of normal expiration. So it's going to be above the tidal volume. The residual volume is something that's gonna stay in your respiratory system because the lungs don't collapse completely to nothing, right? You're gonna force all you want, but there'll still be a residual air, and we call that residual volume. That's going to maintain even if you do the maximum aspiration, you can't really push it anymore. So then your lungs' possible vital capacity would be your tidal volume, your expiratory and inspiratory reserve, like your maximum ability. If you ask to do maximum inhale, maximum exhale, that's gonna be your vital capacity. The total volume of air that could be moved in and out during one breath if you ask to do your best, right? So that is the vital capacity of your lung, and it has a very specific volume. We're gonna be measuring everything in milliliters, the air. So again, this is very average numbers. You guys gonna see what yours are. So the tidal volume, and you're gonna see very similar graph in the software that we have. So here's your tidal volume, look at this. Moving around 500 ml here. This is your tidal volume, 500 ml in and out. The expiratory reserve, forceful expiration, inspiratory reserve, forceful inspiration, and then your vital capacity, here it is. So this is between your maximum inspiration, maximum expiration. This is the vital capacity of your lung. So this is for like the 70 kilogram person, almost 5 liter bottle of the air could be moved. And again, this residual volume is not going to really get out of the residual volume is about 1200, but again, this is like an average numbers, right? So then total lung capacities are going to be, we'll do all this actually calculation in the lab. The only thing I'm gonna probably mention now here is that about 150 ml is the air that sits between the larynx and the bronchioles. It's in this, we call it sometimes dead space, because it's like you move it out, but so if you exhale, the air from the lungs gonna come up, you can't really push it out anymore. So there's about 150 ml just sitting between the pharynx and the bronchioles. And it's always there, but it moves in and out. It gets exchanged because you move it out. It's not like it's ever empty. It's just from the lungs it comes up, but then you inspire, you push it in, right? But it's always there. But it does get exchanged. It's not like it's still there. So it's just like really another way to explain this. So here's your 150 that sits in the upper respiratory pathways. This is the lung capacity, so this is your tidal volume. And then every time you inhale, or like they wanna do exhale, oh sure. Every time you exhale, this 150 that sits in the top will comes out. And then from the alveoli, right, we're going to push air in. There is no need to focus really too much on this kind of the numbers here, because you're gonna get to all of them. It'd be much easier to deal with them. All right, so the muscles that we typically use in respiration. So for the expiration, intercostals, internal intercostals, and of course abdominal muscles. And then diaphragm plays a very important role in inspiration to increase the thoracic cavity. External intercostal, and then actually when you're trying to do a forced inspiration, then the sternocleidomastoids and scalenes, they also play a very important role when you're trying to inhale. Because if you try to inhale very deeply, you will see them, they're both engaged. So these are the muscles that all of this is going to be used in ventilation one way or the other. Okay, so finally let's kind of go back to this ability of lungs to stretch and go back. There's two terms that you guys need to understand, especially when it has to do with the pathology that we're going to get into later. Compliance and elastance. The term compliance meaning ability of the lungs to stretch, meaning they're compliant. You ask them to stretch and they stretch. If the lungs have high compliance, we say they stretch easily. So for example, normal lungs should be able to have a normal compliance, but some disorders make compliance higher than normal. Like remember I mentioned to you that in emphysema you actually have a broken elastic fibers, and some alveoli even break. So to feel that emphysemic lung is very easy, just. But then, because the elastic fibers are broken, they actually don't go back. Elastance is ability to return to the resting volume. So emphysema would be example of the higher than normal compliance. Here's the example of the low compliance, fibrotic disease. So what happens in the fibrotic disease, that so there are elastic fibers, but in addition to elastic fiber, there's a lot of scarring, a lot of collagen and connective tissue. So the lung becomes very stiff. So low compliance will be try to push the air in that very stiff lung is very hard to do. So the low compliance would be fibrotic disease, fibrosis, or if the surfactant is low. Surfactant is low also will be very hard to inhale. So we very often use the fibrotic lung disease as opposed to child for what we call restrictive lung diseases. Restrictive meaning hard to push the air in. So compliance, ability to stretch, elastance, ability to come back from the stretch. Okay?
What happens if the elastic recoil, if it doesn't want to come back?
Yes, like with emphysema, right? Emphysema, high compliance, but then it doesn't go back because the elastic fibers are broken. So what happens that over time you trap more air in there, and actually in the very severe emphysetic disease, you see this very barrel chest, because there's a lot of air that actually doesn't come out. They have issues with the oxygen, with the CO2. CO2 doesn't come out. So we're actually going to talk in the lab a little bit because there's like really interesting shift in the way that the medulla respiratory center controls emphysematic patients, because now their CO2 is always high and rely on CO2. Usually CO2 is the main driver for respiration, like to up it or down. So we'll talk a little bit more about it in the lab, not to confuse everybody, but right now, remember guys, compliance, ability to stretch. The low compliance would be lungs that are too stiff, like a fibrotic lungs. High compliance would be a lungs that actually lost the fiber, very easy to stretch. And then the last one's ability to come back. So fibrotic lung disease, very hard to stretch, but they go back very easily because they're very fibrotic, very they have a lot of connective tissue, they go back. Little did they stretch, they go back really quickly. But the emphysematic patients stretch easily, but then they don't go back. So low elastance, because we were gonna keep talking about like that. High elastance, low compliance, high elastance, you know what I mean? Like it's you should be able to use them. But I think lab will help, so don't feel if you feel like a little bit too much right now. So airway resistance, just like with respiratory, cardiovascular system, wider airways, less resistance to flow, right? Does that make sense? So then bronchoconstriction will increase resistance, and we do know that the bronchoconstriction is the work of parasympathetic nervous system, and then bronchodilation will decrease the resistance, right? Allow for more air to enter, and the sympathetic nervous system, epinephrine on the beta-2 receptors will do the bronchodilation. And if you think about it, when we talked about fight and flight response, right? Adequate oxygen delivery is very important if you're going to be like doing whatever you're going to be doing, fighting, running. So bronchodilation for sympathetic nervous system. And of course, the rate and the depth of the breathing will also be affected and play a role in ventilation. Let me see, what do we have happening here? Again, similarly to cardiovascular, we calculate total pulmonary ventilation by ventilation rates per minute times tidal volume. If you're breathing normally, if you have a 500 ml of the tidal volume times breath per minute, that's going to be your pulmonary ventilation. Now, when people have issues and they go to respiratory medicine, those people are more interested in what we call alveolar ventilation, which they will take your ventilation rate, and they're actually going to do tidal volume minus dead space because they're that particular. But we're gonna actually mostly focus today on the tidal pulmonary ventilation. So, what's interesting also is that cardiovascular system and respiratory system, they work in concert to make sure to optimize ventilation. So look at this. Imagine you have two alveoli here, and here's your arterioles. Low oxygen blood flows in, and then high oxygen blood flows out. If, for whatever reason, this particular alveoli has a high partial pressure of CO2, partial pressure, think of high concentration, higher concentration, higher partial pressure. If it has a concentration of CO2, partial pressure increased, and the concentration of the oxygen decreased, what happens is that the cardiovascular system will constrict the capillaries. Actually, it's kind of probably gonna be at the arterial levels, yes. It will restrict the arterioles because sort of, why should I be bothering trying to do the gas exchange with alveoli that doesn't have enough O2? And this table is the one that kind of helps you to understand what are the stimulus for pulmonary arteries constricting and dilating. So if you have more CO2, it will constrict. That's how you read it. More CO2, pulmonary artery will constrict. If you have less CO2, pulmonary artery will dilate. If you have more O2, it will also dilate because again, you keep thinking about better exchange, better extraction of oxygen. And if the O2 decreases, it will constrict. So it's this very local interplay between the arterioles of the pulmonary circuit and the alveoli to get the most efficient air exchange, oxygen exchange as possible. So, we already know that the bronchodilation and bronchoconstriction will affect the airway. In addition, allergies, infection, mucus accumulation will all change the affect